1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we think about intensive care sedation, we kind of picture a light switch. You give a drug, the switch flips, and the patient is just completely plunged into darkness.
Right, yeah. It's binary. You administer something like, I don't know, a heavy propofol drip, and there's really no middle ground.
Yeah, exactly.
There's no respiratory drive left, no ability for the patient to follow commands. As the medical team, we are basically taking total, absolute control of their physiology.
And functionally, that is exactly what we have needed a lot of the time, you know? But then you encounter a medication that doesn't just flip the switch. It's like it installs a highly sophisticated dimmer.
Oh, I like that. A dimmer switch.
Yeah, one that actually lets you talk to the patient while they're on it without sacrificing their comfort.
Which, I mean, that fundamentally changes the entire landscape of critical care. You are no longer flying blind with your neurological assessments.
Right.
You don't have to guess what's happening in the brain because you can actually just ask the patient.
Exactly. And that is exactly what we're getting into today on this deep dive. We are tossing out the textbook fluff and acting as your elite critical care pharmacology instructors to break down a genuinely fascinating, vital medication, which is Dexmedetomidine.
Right, which most of you probably know better as Precedex.
Yes, Precedex. We are aggressively applying the 80-20 Pareto principle here. So we're cutting through the noise to focus strictly on the highest yield clinical facts.
The 20% of info that gives you 80% of the results.
Exactly. The core mechanics of why it's chosen and the pearls you actually need to keep your patients safe and ace your board exams.
Because when you're dealing with critical care drugs, information overload is genuinely dangerous.
Yeah.
You know, you need to understand what a drug does to the body and exactly how it can turn on you if you aren't paying attention.
Okay, let's unpack this. Dexmedetomidine is fundamentally known as a unique sedative used in the ICU. But as I was looking through our source material, it has some highly surprising formulations and uses completely outside the ICU, too.
Oh, absolutely. It's wild.
But before we get into how to give it or when to hold it, we need to understand the underlying machinery. So what is this drug actually doing in the brain?
Well, at its core, Dexmedetomidine is a relatively selective, centrally acting alpha-2 adrenergic agonist.
Okay, that is a mouthful.
I know. So let's translate that into how it actually creates a physiologic effect. It works in the nervous system in two main ways, presynaptically and postsynaptically.
Let's break those down. What is happening on the presynaptic side?
So presynaptic activation of these alpha-2 receptors essentially acts as a brake on the release of norepinephrine.
Norepinephrine is like the gas pedal, right?
Right. It's a major excitatory neurotransmitter. So if you block its release, you are effectively terminating the propagation of pain signals before they can even travel further.
Oh, wow.
Yeah, that gives you your analgesic effect.
So it's stopping the pain signal from being handed off to the next nerve. And then what about the postsynaptic side?
Postsynaptic activation in the central nervous system inhibits general sympathetic activity. It just drops your overall sympathetic tone.
Okay, got it.
And when the sympathetic nervous system, your fight or flight system powers down, that leads directly to a decreased blood pressure and a decreased heart rate.
So the end result of manipulating both of those receptors is sedation, analgesia, pain relief, and anxiolysis.
Right, which is a massive reduction in anxiety.
I always like to picture this mechanism like a really effective professional bouncer at a chaotic nightclub.
Okay, let's hear it.
So the central nervous system is the club. Dexmedetomidine is the bouncer. But instead of aggressively kicking people out, throwing punches, and causing a massive scene, this bouncer just quietly turns down the music.
That's the postsynaptic sympathetic drop.
Exactly. And at the same time, he stops letting new rowdy guests inside. Those rowdy guests are the norepinephrine. By just stopping the influx of chaos, the whole place naturally calms down.
That is a highly accurate way to visualize it. And if we want to look at the the deep pharmacology of where this bouncer is standing, the drug is working heavily in a specific part of the brainstem called the locus coeruleus.
This is coeruleus, okay.
Yeah, that area is the brain's predominant noradrenergic center. It's basically the panic and wakefulness headquarters. Dexmedetomidine activates specific G protein-gated channels there.
Which does what, exactly?
To put it simply, it opens cellular exit doors, letting potassium leak out of the neuron. This makes the neuron too negatively charged to fire and stops it from releasing more neurotransmitters. It is a profoundly targeted, elegant mechanism.
But wait, I have to push back here for a second. When you say centrally acting alpha-2 agonist, my brain immediately goes to clonidine.
Sure, yeah, that makes sense.
We use clonidine all the time for blood pressure, sometimes for withdrawal or anxiety. So is dexmedetomidine just a much more expensive intravenous version of clonidine?
That is the exact logical leap a lot of people make. But no, it is not. And the distinction is a major clinical pearl here. Dexmedetomidine is 8 times more specific for alpha-2 receptors than clonidine.
8 times more specific. What does that actually look like in the numbers?
The activity ratio of alpha-2 to alpha-1 for dexmedetomidine is a staggering 1,620 to 1.
Whoa.
Yeah. For clonidine, it's only 220 to 1.
1,620 to 1. That specificity is just, I mean, it's wild.
Exactly. It means dexmedetomidine is acting with absolute pinpoint precision on those alpha-2 receptors. Because it is so specific, it gives us profound sedation and analgesia without broadly hitting other receptors that might trigger unwanted side effects.
Well, at least until you start pushing massive doses.
Right, exactly.
Knowing that it acts with that kind of 1,600 to 1 precision, it begs the question, why isn't this the default for every single patient? Why are providers still reaching for propofol or benzodiazepines if this mechanism is so elegant?
It really comes down to what you actually need the patient to do. In the intensive care unit, the primary use is for sedation induction and maintenance in mechanically ventilated patients. We're talking adults, children, and neonates.
And for procedural sedation too, right?
Yep, that too. But the defining reason a provider chooses it over a benzo or propofol, the ultimate why choose this drug takeaway, is that it provides what we call arousable sedation.
Arousable sedation.
Yes. And it has extremely limited effects on the central respiratory drive. In fact, clinical guidelines explicitly recommend non-benzodiazepine sedatives like dexmedetomidine over benzodiazepines for mechanically ventilated patients in non-cardiac surgery.
Specifically because it reduces the need for other heavy painkillers, right?
Spot on.
I have to pause on that phrase, though. Arousable sedation. Honestly, it sounds like an oxymoron. If a patient is deeply sedated enough to tolerate a breathing tube, how are they arousable? Aren't those two states mutually exclusive?
It does sound contradictory until you see it happen in the room. With heavy anesthetics, the patient is totally unresponsive. You perform a sternal rub or call their name, and you get very little, if any, purposeful response.
They're just locked away.
Exactly. But a patient on a dexmedetomidine drip is entirely different. You can walk into the ICU room, call their name, and they will calmly open their eyes.
Oh, really?
Yeah, they can follow complex commands for a neurological check, like squeeze my hands, wiggle your toes, look up. And the moment you stop stimulating them and step back, they just peacefully drift right back to sleep.
Going back to that dimmer switch analogy, you just dial up the lights for 30 seconds, do your neuroassessment, ensure their brain is functioning properly, and then dial the lights back down.
Which is invaluable in neurocritical care.
I can imagine. But what about outside the ICU? Because the sources show some genuinely surprising formulations that I wasn't expecting for an intensive care drug.
Oh, this is where it gets really innovative. What's fascinating here is they've actually developed a sublingual and buccal film formulation. The brand name is Igalmi.
And this isn't for putting someone on a ventilator, right?
No, not at all. This formulation is specifically used for the treatment of acute agitation associated with schizophrenia or bipolar II disorder in adults.
Wait, a film? Like one of those dissolving breath strips?
Exactly like that. It's a dissolving film that delivers the drug right into the bloodstream through the mucosa of the mouth.
Okay, that makes sense.
Think about the clinical reality of a psychiatric emergency. Trying to start a traditional IV on a patient with severe acute agitation is incredibly dangerous.
Yeah, for both the patient and the healthcare staff.
Right. And if you inject them with heavy, typical antipsychotics or massive doses of benzodiazepines, you risk knocking out the respiratory drive entirely.
So you're bypassing the needle, getting a fast onset through the mucosa, and preserving their drive to breathe while still bringing their sympathetic nervous system back down to a manageable level.
Right. And we are seeing other off-label uses emerge too. For example, intranasal administration for pediatric procedural or pre-anesthesia sedation.
Oh, intranasal.
Yeah, they literally just drip the liquid into a child's nostrils 30 to 60 minutes before procedure. No traumatic FAV start required.
That is brilliant. Anything to avoid traumatizing a kid with a needle before surgery.
We're even seeing continuous IV infusions used off-label for severe alcohol withdrawal, allowing us to manage those brutal withdrawal symptoms without suppressing their breathing.
But look, arousable sedation and magical dissolving films sound perfect on paper. The reality is, we are actively and aggressively manipulating the sympathetic nervous system.
Yeah, we are.
That has to come with serious risks. Let's look at the complications.
This is where we need to think logically about what we are doing to the body. Following our reasoning pattern, if the mechanism is sympathetic and the physiologic effect decreases sympathetic tone, what is the inevitable cost?
The heart slows down and the blood vessels relax.
Precisely. Therefore, the most dangerous, logical adverse effects are severe bradycardia and severe hypotension.
And the numbers on this in the literature are no joke. The source data shows the incidence of hypotension can be up to 56%. Bradycardia can hit 62% of patients.
More than half.
Yeah, more than half. Those are your absolute priority safety parameters to monitor. But here's where it gets really interesting. As I was reading through the pharmacology data, I found a massive physiological paradox.
Oh, the IV push paradox.
Yes. If you give this drug via a rapid IV push, it actually causes transient hypertension, high blood pressure, followed immediately by severe reflex bradycardia. How does a drug designed to lower blood pressure suddenly cause it to spike?
It is a brilliant paradox. And it all comes back to receptor location and the speed of delivery. Remember earlier we said it's a centrally acting drug.
Right, it's supposed to work in the brain.
But if you slam it into a vein as a rapid IV push, a massive, highly concentrated bolus of the drug travels up the arm and hits the peripheral blood vessels first.
Before it even gets to the brain.
Long before it ever crosses the blood-brain barrier. And in the periphery, those massive doses activate alpha-2 receptors on the vascular smooth muscle itself.
Okay, so it hits the vessels first.
Right. When those peripheral receptors get flooded, they cause the blood vessels to acutely and violently clamp down. That intense constriction is your sudden hypertension.
So the pipes suddenly shrink, the pressure shoots up, and then the body panics.
Exactly. Your body's baroreceptors, the pressure sensors in your carotid arteries, they sense that sudden, dangerous spike in blood pressure. They sound the alarm, send a signal down the vagus nerve, and tell the heart to reflexively slam on the brakes to compensate for the high pressure.
Oh, wow.
Yeah, that's a severe reflex bradycardia. It's a dual-threat hemodynamic crisis, and it is caused entirely by the provider pushing the drug too fast.
That completely connects the dots. It's not just an arbitrary nursing rule to memorize. You know, the underlying physiology literally demands that you go slow or you will crash your patient. Speaking of rules and apparent contradictions, I found another one in the text that we need to clear up. The source explicitly states dexmedetomidine has limited effects on respiratory drive.
Which is true.
Right, as we discussed, that is a massive selling point. But then, right there in the moderate adverse reactions chart, it lists respiratory depression happening in 37 to 67% of cases. How do we reconcile limited effects on respiratory drive with up to 67% of patients having respiratory depression?
It's a really great catch, and it's all about clinical context and the definitions of respiratory failure. When we say it has limited effects on respiratory central drive, we are comparing it directly to drugs like fentanyl or propofol.
Which will reliably cause apnea.
Right. They will shut off the brainstem's pacemaker, stopping the patient from breathing entirely if pushed far enough. Dexmedetomidine preserves that brainstem drive. The brain keeps sending the signal to breathe.
So if the brain is still sending the signal, why are they depressed?
Because these are critically ill patients. They are profoundly relaxed by the medication. They often have existing lung pathology like pneumonia or ARDS. And their upper airway muscles can become so relaxed that the tongue falls back and obstructs the airway.
Ah, so the breathing mechanics fail, even if the brain is still trying.
Exactly. While the drug isn't shutting off the brain's breathing center, nurses and providers must still vigilantly monitor for respiratory depression, hypoventilation, and hypoxia. You can never just drop your guard just because a drug is marketed as safer for the respiratory system.
That makes perfect sense. The signal is there, but the anatomical pathway is compromised. So given these hemodynamic and respiratory risks, when do we definitively hold this drug?
Because of the profound hemodynamic risks we just covered, you hold additional doses. And this is especially true for that sublingual psychiatric formulation. If the systolic blood pressure is less than 90, the diastolic is less than 60, or the heart rate is less than 60 beats per minute.
What about orthostatic changes?
Yes. You also hold it if the patient is experiencing significant orthostatic postural drops. If they stand up and their pressure absolutely tanks, you do not give them more of a sympathetic drug.
All right, let's translate all of this into strict medication administration protocols. Based on what we just discussed about the physiological paradox of peripheral constriction, rule number 1, and a massive NCLEX or ATI test point you'll see, is never 5E push.
Never. It must be infused.
But what about the loading dose? The formal guidelines say to infuse a loading dose over 10 minutes to get them up to a steady state.
And here's a massive real-world clinical pearl. In actual day-to-day clinical practice, those loading doses are frequently completely bypassed.
Wait, really?
Yeah, the source text explicitly states this for adults, children, and neonates. Providers often skip the loading dose entirely and just start the continuous maintenance drip.
I guess because even over 10 minutes, flooding the system with that much drug right out of the gate still carries too high a risk of inducing that severe bradycardia and hypotension we mapped out earlier.
Precisely. It is infinitely safer to just start the drip and slowly, patiently titrate it up to your target sedation level rather than risk a hemodynamic crash from a loading dose just to get them asleep a few minutes faster.
As for the actual IV logistics, the standard ASHP concentration you'll encounter is 4 micrograms per milliliter, usually mixed with 0.9% normal saline.
Right, and it is very chemically stable.
Yeah, good for 48 hours at room temperature, but drug interactions are critical here. And I don't just mean receptor interactions in the body, I mean physical IV line compatibility.
Oh, this is so important.
You cannot co-administer dexmedetomidine through the same IV line as blood, serum, or plasma. The physical compatibility simply has not been established, meaning we don't know if it will precipitate, crystallize, or degrade in the line.
And regarding metabolic interactions, it actually has very minimal cytochrome P450 interactions, mainly just CYP2A6. So it plays relatively nicely with other medications in terms of liver metabolism. It's not going to aggressively block other drugs from breaking down.
Let's talk about the sublingual and buccal formulation at Galmi, because the administration rules for this film are highly specific. If you are using this for acute psych agitation, you must keep it in the foil package until the exact moment of use.
And if you have to cut it to give a partial dose, you must use clean, absolutely dry hands and dry scissors.
Because it's a film, right? Any moisture will ruin it.
Because it is a highly calibrated mucosal delivery system. Any moisture, even a drop of sweat on your glove, will begin dissolving the film and ruin the dose before it even gets to the patient.
Exactly. You place it under the tongue or inside the lower lip. The absolute priority for client education here, they cannot chew or swallow it. It has to dissolve into the mucosa.
And they cannot have food or drink for at least 15 minutes if it's sublingual, or a full hour if it's buccal.
And tying back to everything we discussed about sympathetic tone and blood pressure dropping, the patient must remain seated or lying down after administration, right?
Right. The orthostatic hypotension risk is very real, and they can easily faint if they jump up, and obviously no driving or operating hazardous machinery for at least 8 hours.
Okay, what about organ impairment? If I have a patient with liver failure or kidney failure, do I need to adjust these doses?
This is a vital distinction to make. You absolutely must consider dosage reductions for hepatic impairment liver dysfunction.
Because the liver metabolizes it.
Yes, the drug undergoes extensive biotransformation in the liver, specifically a process called glucuronidation. Think of glucuronidation as the liver slapping a molecular barcode on the drug so the body knows it's time to pee it out.
Okay, I like that barcode analogy.
If the liver is failing, say, a patient has cirrhosis with a high Child-Pugh score, that barcode system is broken. The drug isn't processed, so it just circulates and builds up to toxic heart-stopping levels. That's why you must drastically reduce the dose or titrate very carefully.
Okay, so the liver is the main filter. What about the kidneys?
Interestingly, no specific dosage adjustments are required for renal impairment.
Really? None?
None. Even though the metabolites exit the body through the urine, the active drug has already been dealt with and neutralized by the liver. So bad kidneys don't change your initial dosing strategy for the active drug.
Liver matters. Kidneys don't for dosing adjustments, at least. To see how this actually plays out in the wild, let's look at 2 brief clinical scenarios.
Let's do it.
Imagine you are in the ICU. You have a mechanically ventilated patient who is recovering from major non-cardiac surgery. The critical care provider orders a dexmedetomidine continuous IV drip and specifically writes in the order, no loading dose. Why is this the exact right call?
It's the right call because the bedside nurse needs to wake this patient up every 2 hours to perform accurate neurological assessments. They need that specific arousable sedation.
Right.
Furthermore, as they prepare to extubate the patient to pull the breathing tube out, they need the patient to maintain their own central respiratory drive.
Yeah.
And the provider bypassed the loading dose entirely to protect the patient from a sudden blood pressure and heart rate crash. It checks every single box perfectly.
It's exactly what the drug was built for. Okay, scenario 2, psychiatric emergency. An adult patient with a known history of bipolar I disorder arrives in the emergency department experiencing severe acute agitation. The provider orders 180 micrograms of the sublingual film.
Also an excellent application. They're utilizing the centrally acting sympathetic properties to rapidly calm the nervous system and achieve a reduction in agitation.
And no needles involved.
Exactly. Without needing to force an IV into a highly agitated patient, and without using a heavy antipsychotic that might cause profound respiratory depression or severe extrapyramidal side effects.
And for both of those scenarios, our evaluation of effectiveness is exactly the same, right? We know the medication is working when we achieve the target level of arousable sedation in the ICU or a measurable reduction in that acute agitation in the ED, all while maintaining stable hemodynamics.
Meaning their heart rate and blood pressure having crashed. Hemodynamic stability is the tightrope you walk with this drug from start to finish.
Which brings us to the final 80-20 review. I want to give you a memory hook right out of the gate to lock this physiology into your brain.
Always helpful to have a hook.
When you think of this drug, remember, Precedex keeps you dextrous enough to wake up, but slows your heart to a crawl.
Okay, I like it.
Or, if you prefer a simpler acronym, DAX equals decreases excitement excellently.
Decreases excitement excellently. That covers both the ICU sedation and the psychiatric agitation perfectly.
So what does this all mean? Let's bring it home with the absolute essentials. The 20% you absolutely must know to master this drug for clinical practice and your exams.
I'll take the first one. Number 1, it is a highly specific alpha-2 agonist. Remember, 1600 to 1 specificity, making it 8 times more specific than clonidine.
Number 2, it offers arousable sedation without shutting off the brainstem's respiratory drive. That is its superpower.
Number 3, because it blocks the sympathetic nervous system, the major safety concerns are severe bradycardia and hypotension.
Number 4, because of those safety concerns, your priority intervention is never rapid 4V push, because that paradoxically causes dangerous transient hypertension followed by severe reflex bradycardia as the body panics.
And similarly, IV loading doses are frequently bypassed entirely.
Number 5, the sublingual or buccal film, IGALMI, is a game changer for acute schizophrenia or bipolar agitation. Just remember the strict mucosal administration rules: dry hands, don't chew or swallow, and wait 15 minutes to an hour to eat or drink.
And number 6, it requires hepatic dose adjustments for liver impairment because the liver processes it, but no renal adjustments are needed. And finally, never physically mix the IV form with blood products.
Those 6 facts are your ultimate survival guide for dexmedetomidine. But before we wrap, I want to leave you with a final thought to mull over.
Yeah, if we connect this to the bigger picture of where medicine is heading, we now have a highly selective alpha-2 agonist that can achieve targeted arousable sedation via a simple sublingual film, all without shutting down the brain's fundamental respiratory drive.
Which is huge.
It is. So the question becomes, how might this level of highly selective neurological targeting revolutionize the future of outpatient anxiety and panic treatments?
Are we looking at a future where these powerful tools move completely out of the intensive care unit and into our daily lives?
Right, allowing people to safely manage extreme stress or panic attacks at home without losing their ability to function.
It really makes you rethink what sedation even means. We started this deep dive talking about a light switch versus a dimmer. Dexmedetomidine proved that we don't have to plunge our patients into total darkness to keep them calm. Sometimes we just need to quietly turn down the noise. Thank you for joining us on this deep dive. Keep questioning the physiology, keep applying that 80-20 rule, and we'll see you next time.